My background is in nonprofit and academia, but I'm going to wear a different hat today. I was recently invited last year to join the board of directors of Chemonics International, which is one of the largest USAID subcontractors. It's a for-profit company. And when I first heard about it, I was pretty uneasy with the idea of it, but it's actually been an incredibly illuminating experience. And so Beverly and Kathy thought that maybe sharing my experience, I think maybe we can take something from it and learn for academia and nonprofit and public sector as well. So just to dispel any myths, just to explain how the service, how it works, is USAID identifies national interests, projects that, development projects that would serve national interests, say a water project, and that would serve this many people in this particular region. They send out a request for proposals, not so dissimilar to RFAs from NIH. And both for-profit and not-for-profit companies can apply for them. And they're judged based on feasibility and cost efficiency. So the likelihood of being able to succeed and cost efficiency. The main difference between the two in this context is that for-profits include a fee. And this is a pre-negotiated fee. It's expressed as a percentage of the entire budget, but say 5%. It might be higher in places where there's higher risk, like in a war zone. It might be lower in an easy setting. But the fee is negotiated in advance and is part of the budget that's proposed to USAID. And not-for-profit, they don't include that in their original budget. And some of the observations that I've made is that in many ways, because they're for-profit, they're actually a lot more accountable, I think, than nonprofit, given that it's government money and they're for-profit and they're under so much scrutiny. They're also much more likely than nonprofits to implement very strictly, exactly like USAID wants, because then and NGOs that might go off on a little bit of a tangent, they're less regulated. They're more likely to be cost efficient, which is a question mark. Incentives for quality delivery. This is one of the interesting things that I discovered. One thing that I found fascinating about this model is that it brings, usually social service and health services are not in the market economy. It's like a separate social good. And in this model, it actually becomes incentivized to do quality work within the market economy. Another innovation that I think is, when I first heard it, was horrified, and I thought it was really actually quite brilliant, is they do non-expert-led teams, which would never happen in academia. But basically, they have a water project, they don't have it led by a water expert, which seemed crazy to me initially, but what they do is they have someone with management skills and leadership skills who wants to be a manager run the project and channel the expertise of the expert. Because not all experts are managers, as we know, and not all experts, very few of them want to be managers. And so it's really kind of an interesting concept. And then the last piece, which I don't know if it's unique to Chemonics or not, but I found this really fascinating, that their first pillar of importance is impact and having positive impact in development. But their close second priority is staff satisfaction and staff retention and staff development. As soon as a person begins working there, in the first year they have a mentorship program where they are taught all the different options, career pathways that they could pursue, and they always try to recruit from within. So there's not only a fiscal benefit, but there's like a career path and a way forward, which I think we need to think about, but I'll get back to that. So health has always been recognized as a human right, but it was recognized internationally in the 1948 in the Universal Declaration of Human Rights, and then again in the Millennium Declaration, I'm sure in other places as well. But more recently, we're sort of looking at the reality of health being in the market economy. And the first sort of, this is an oversimplification, but privatization was a movement in the 70s, 80s, 90s of privatizing healthcare and introducing user fees and all these things which were disastrous in most poor settings and reduced access for for the most needy of patients. But the reality is that we are in a market economy, but maybe not all of it is necessarily negative. In 1995, the World Mental Health Report, which was by the Harvard Group, came up with this concept of DALYs, disability-adjusted life years. And what's interesting about this is it's a way of almost quantifying there's a moral incentive to treat depression, but this disability piece is something quantifiable, and it's something you can communicate to economists and other audiences that aren't so moved just by the human right argument. Task shifting is another effort to economize in some ways. Conditional cash transfers, that's a newer innovation that also makes me uneasy thinking about it, but it seems to work. And most of the evidence has been effective, and I think money talks. People come for service. I don't know. We need to be more open-minded about it. My final thought. So privatization and healthcare didn't work. So in terms of the service delivery piece, did not work. It's a disaster. But there may be another role for for-profit, which is in the implementation piece. So once in academia and nonprofit, we come up with these models, and maybe the for-profit companies can bring it to scale because they're very efficient and they're deliverable based. It's just an idea. I feel like we need to, in the global mental health community, be stronger about the economic angle for why we need to treat mental health, not because it's just a human right, but because people listen. Economists only listen when there's a quantifiable reason, unfortunately, and governments in the same way. So we need to think about things like incentives at the local level. Oh, this was the piece. That monetize incentives for staff, maybe that when they screen or they do referrals or they follow up, or you pay more people in rural settings where they don't want to be serving. And the career development opportunities is the one last piece. When we're talking about task shifting, it's really important in the public system, in the community health worker model. There's no upward mobility. There's no career pathway, and so things like monetized incentives as well as career incentives support both mentoring support, but also having some sort of pathway. Maybe if you're a community health worker for this period of time, then you become a trainer and you move up. But the idea that it's going to be that's important for sustainability, and I'll leave it at that.